note, the pancreatic duct was not dilated, the pancreatic parenchyma was of good volume, and there was no vascular compromise. So that's your patient, jaundiced. So he's jaundiced, no tissue confirmation at the moment, but distal biliary obstruction secondary to a pancreatic mass. So the question is, at your trust, what would be the next management step? Would you do ERCP and acquire tissue via brush cytology and then insert a stent? Would you do a combined EUS with fine needle biopsy and an ERCP? Would you do a combined EUS FNB and then EUS biliary drainage? Or would you perform a PTC for biliary decompression? Please.
And just to reiterate, this is what you would do at your trust.
Okay, so the majority of the room would perform ERCP and brush cytology only, followed by EUS FNB ERCP, and then followed by joint EUS FNB and EUS biliary drainage.
I think there's an awful lot of discussion to be had there. I wonder, why don't we just hear what you did, and then we'll discuss afterwards.
Fine, so what I'll say is, for this particular patient, there was a rigorous multidisciplinary team approach involving widespread discussion with consultant colleagues, as well as our pancreatic and biliary surgeons. And an MDT decision was made to proceed with an EUS FNB and then an EUS biliary drainage. The procedure was performed under conscious sedation, and first an EUS FNB was performed. A linear endoscopic ultrasound was performed, and the head of pancreas mass was identified. Next, fine needle biopsy was performed using a 22 gauge acquire needle. 4 passes were done, which yielded excellent cause, and these were sent by a fast-track histology. By this time, the patient was a little agitated, therefore we used a wire-guided EUS choledochoduodenostomy. So here the dilated common bile duct was punctured with a 19 gauge needle, and contrast was injected, which you can see appearing on the cholangiogram. Now, so for the non-EUS colleagues in the room, there you can see a linear endoscopic ultrasound. The first kind of anechoic structure which the needle is going into is a common bile duct. Prior to this, we found a good location, which is typically the proximal common bile duct. We did a colour flow Doppler to exclude any vessels in the needle trajectory, and we measured the common bile duct, which at this stage was about 16 millimeters, which is within the remit of performing EUS choledochoduodenostomy. The anechoic structure below that is the portal vein. Next, the 0.025 Visiglide wire from Olympus was inserted deep into the intrahepatic ducts. And now, with a stable scope position, we were able to perform EUS choledochoduodenostomy. We do this via the Axios system made by Boston Scientific. The Axios device was connected to a generator and powered and set to pure cut settings, and the catheter tip was then advanced just so it's visible under the EUS transducer. So, the catheter tip was energized and advanced through the duodenal wall into the common bile duct, ensuring a decent amount of catheter was within the bile duct. The catheter was locked and the device was disconnected from the generator. The yellow safety lock was removed and the stent hub was retracted back, which released the biliary flange right about now. The catheter was then unlocked and retracted back so that the distal flange sat gently against the bile duct wall. Finally, the stent hub was retracted and the proximal flange was released from the channel of the endoscope by unlocking and advancing the catheter control hub whilst gently retracting on the scope. Upon release, the iatrogenic fistula between the bile duct and duodenum was made, leading to the immediate gush of pus and bile. This led to immediate biliary decompression. Finally, a 4 centimetre 7 French double pigtail stent was placed through the axial stent. So, how did our patient do? Did very well. We were managed to acquire good amounts of tissue, as well as decompress his bile ducts in one sitting with one scope. Both his bilirubin and his renal function completely normalised. We did not need to give any rectal non-steroidal anti-inflammatory drugs. He had a stat dose of intravenous antibiotics to combat any septic shower. He had no post-procedural complications, and the final diagnosis came back as a T2 N0 periampullary adenocarcinoma. He was then subsequently referred to the surgeons, and I've been told that he's been booked for his pancreatic angiodenectomy on the 1st of July. So overall, a fantastic outcome with a combined procedure. I'm now going to pass it to Dr. Huggett, who's going to talk more about the evidence and the rationale for doing the procedure this way.
Aaron, thank you for that presentation. And I suspect Matt will be addressing this in a moment, but perhaps not surprisingly, there's a few questions from the audience as to why an EUS biliary drainage approach is taken ahead of what would be perhaps more conventionally the more conventional approaches of the RCP.
Yeah, so we talked about this when we got the referral with our pancreas surgeon. So the key thing about him is that he is operable. He wasn't going to have any chemotherapy pre-surgery. He has an acute kidney injury, and we felt that he would be at high risk of post-EOSCopy pancreatitis because he had a normal pancreas and non-dilated pancreatic duct on imaging. So we felt that given that if he were to have post-EOSCopy pancreatitis with his AKI, he would potentially be rendered inoperable. And we have had a number of patients who've had post-EOSCopy pancreatitis that have been rendered inoperable. We felt he was a particularly high risk, so that's why the decision was taken to do a primary EUS cardiac biliary drainage.
A few technical aspects of the procedure. One of them was, is the technique of deploying the distal flange different in CDD when compared to pseudocyst drainage? The technique of deploying the distal flange is different for CDD as compared to pseudocyst drainage.
It is. If you deploy it just in one step, like you would with the pseudocyst drainage, you will deploy the distal flange within the wall of the bile duct or between the duodenum and the bile duct. So you need a stepwise approach. You need to puncture initially, open a little bit of flange, advance the catheter, open a bit more, advance a bit more, and then open the final bit of flange, and that enables you to stay in the same place without the stent being deployed or multiplied.
The other question was, what are the optimal size of the duct for EUS cardiac biliary drainage?
Greater than 15 is safer. We've certainly done less than 15. I think if you use a wire-guided approach, as we did with this patient, you have a bit more of a safety window, but generally over 15 millimeters, we would be looking to attempt this.
And why did you choose wire rather than freehand?
So in this
I know you used.
Yeah, so in this particular patient, he was quite difficult to sedate. He became quite wriggly during the procedure. So at that point, I had to make a decision whether to go for a freehand approach would be our normal in this setting. But obviously then once you punctured the duct with an axial system, you make quite a big hole in the duct. And my feeling was that actually what we should do is get access to the duct. We make a hole with an access needle, and then we decide not to do the stent. You probably won't end up with a significant bile leak. So we got access, got a wire in, and then we made the decision that we could sedate him enough for the rest of the procedure. I think if this was done under propofol or general anesthesia, I would have gone for a freehand approach.
And one of the other questions, obviously, did you need to do an FND when you know it's a resectable lesion?
Yeah, so it depends on your centre. In our centre, the pancreas surgeons will not operate anymore without histology, much like the oncologists won't operate without histology. They won't give chemotherapy without histology.
I just wanted to pick up on that because I think the majority response from the audience was ERCP and brushings. Do you have any comment in relation to that? I think brushings is
I
appropriate.
mean, it all depends on what's available in your centre. Obviously, brush cytology sensitivity is 30, 40, 50% maximally. With EUS FMB, it should be in the 90s. So we use that as a first-line diagnostic test. Plus, in addition to that, you can do immunohistochemistry, you can look for certain biomarkers, subsequent sets off for research. There are a number of other factors which you can use for the biopsy.
I guess, yeah, carry on with your presentation now.
Okay. So there've been a number of studies now looking at primary EUS biliary drainage with ERCP, and the most recent one, which was published last year, was the Elements study. And the difference with this one is that it's actually included patients who were borderline operable, so patients who were having neoadjuvant chemotherapy and then with a plan to have surgery afterwards. Most other studies have looked at patients who are inoperable. This study was randomized between the two arms, and they found that there was a reduced post-procedure pancreatitis risk in the EUS biliary drainage group, and that's in keeping with most other studies looking at this. It's a shorter procedure time, and obviously you're using less fluoroscopy. And actually, this study looked at pancreatic duodenectomy outcomes, and there was no difference between them. So we have a number of patients. We've got a series of patients whereby patients have had EUS biliary drainage, and anecdotally, and also the evidence is difference in terms of the surgical outcomes. Patients can safely have surgery with an EUS biliary drainage approach. But our sort of key points are not to go straight for this in every single patient. You need to consider obtaining tissue at the time of doing biliary drainage, but you need to really think about your patient. Is the patient going to go down a chemotherapy pathway or a surgical pathway? Do you need tissue? If it's someone who's not going to be fit for chemotherapy, then possibly brush cytology and ERCP would be appropriate in most cases. And then if a decision later for the patient to have chemotherapy, then the EUS FMB would be reasonable. You also need to think about sedation. Can you do a prolonged double procedure on these patients? And that is really dependent on your setup in your hospital. In the case of failed ERCP, you should be engaging in your local network and referring failed ERCP cases to your hub. Now that may be for EUS biliary drainage or for PTC, but the data now is suggesting that EUS biliary drainage is preferred over PTC due to the low complication rate. And just, I think this case demonstrates that there is an evolving role for primary choledocodiegenostomy, but in very selected cases, and there needs to be a careful and deep discussion, particularly with your surgical colleagues, and that training and surgical support are mandatory when you're doing these procedures. We are currently in the process of writing UK guidelines for therapeutic EUS, and we'll be engaging with colleagues about how best to train people in a UK-specific way. Thank you very much.
Matt, and in fact, you touched on the final question I wanted to ask, and I'm going to put this question to Arif, if you don't mind. It's one or two questions. So there's a couple of questions about training, specifically in interventional EUS. So I just wondered if you could comment yourself, Arif, in terms of the journey that you have gone through and are going through in terms of interventional EUS and what your expectations and experiences are.
Of course, it might be a biased answer because Simon's my trainer, but so I did my training in Oxford with Dr. Bakali and did a bulk of ERCP. I've done quite a little amount of EUS actually, so it was my first ever fellowship, but I'm very fortunate that there was a lot of volume, and especially in terms of interventional EUS. And I think from my perspective, it being my first fellowship, the priority for myself was getting the basics and the foundations correct in terms of the stations, the appropriate landmarks, mainly report writing, as well as FNA and FNP. And now at the latter end of my fellowship, and hopefully going to embark onto the Axios training course from Boston Scientific, where you practice multiple times with a animal model, and then hopefully during the consultant job to try to work with your hub and spoke in terms of providing the bulk and meat and potatoes, which is diagnostic and FMB, but also working with the hub to help with interventional procedures as
started training ERCP. And my initial response was, I'll give you Robert Logan's phone number because we're absolutely desperate for consultants to train ERCP or to enlarge the ERCP workforce. The workforce survey that we just completed suggests that 1/3 of you, if you are ERCPs in that science, will retire within 5 years. So we're going to lose 1/3 of our ERCP workforce, but we've got increasingly impressive field interventions through the EUS. So I guess it's a question really for Matt and for you two. I've noticed that all the representatives there are doing fellowships. Is that the way that the young doctors in the audience are going to learn to do these procedures? Or is it not technically? We published the pathway to certification very recently. So some comments on how you see the training in the US. So I'll talk about training aspect, and obviously Simon has got a lot of knowledge about how the service provision is going to look like in the next 5 to 10 years, or projected to look like. Yes, I think finally, after years and years of trying, last year we now have a robust training and JAG approved training and certification pathway for both ERCP and EUS. The struggle and the challenge, which is what we discussed in the endoscopy CRG yesterday, is how do we get trainees interested to train in AV endoscopy? That's the first thing we can